Professor of Vascular and Endovascular Surgery in Mansoura University. He will talk about chronic iliofemoral venous occlusion, hybrid revascularization or bypass.
As we look for the severity of iliofemoral DVT, we will find that going with a very high risk, especially when the occlusion involves both the iliac and the femoral, the common femoral system. And this debilitating PTS could happen in around 50% of the individuals, leaving some of them in around 90% with venous insufficiency, 15% with ulceration, 15% with venous claudication, and 40% with impaired quality of life. Looking to the pathophysiology of these individuals with the main problem of the ambulatory venous hypertension, particularly is severe when valvular and obstruction coexist. And as the valvular function can be assessed with Doppler, we will look at the residual venous obstruction which goes undetected, leading to under appreciation of its contribution to the PTS morbidity. When we go through the escalation in the system of typing from type 1 to type 5, with starting with the mechanical compression by the May-Turner syndrome, and then involvement of the whole iliac system, followed by the involvement of the common femoral, and then extension to one of the deep femoral or superficial femoral or both together, we will find this escalation of the system has its impact on the severity of the PTS, as well as its impact on the strategy for management. For example, if from type 1-3, we can manage these cases with endoluminal revascularization and stenting, while in type 4 and 5, we will need endophlebectomy with a hybrid technique. We have to go through the assessment system of the PTS first by using a various scoring system ranging from the VCSS to the Villalta score, and encroaching towards the SEEB, and lastly with the veins quality assessment score. And taking these 10 points in the VCSS and the 11 points in the Villalta score with a highest score of more than 14 or the presence of a venous ulcer, we can go through either the conservative treatment of the mild cases and moderate cases, and we can have a better assessment if we don't get a satisfactory improvement with the conservative treatment. And with the assessment, we may find that the patient is having either a reflux or a non-acute obstruction of the system. So in the cases of the reflux, we can treat accordingly by sepsis or venoplasty or vein transposition, or we may go through a kind of venous ablation of the superficial system. On the other hand, we have from type 1 to type 3, we can go through the iliofemoral stenting by proximal crossing, either through the popliteal, the femoral, saphenous, contralateral, or jugular approach. And once in one type 1 and type 2, we have to stent from healthy to healthy, while in type 3, we got to extend our stenting system to the common femoral vein. Looking at this area, stenting from healthy to healthy, we have to extend from up to 1/2 to 1 centimeter inside the IVC, and extending to the most healthy part of the common iliac system without skip lesions, having a bridging of 1 to 2 centimeter in between, and we have to assess for total disappearance of the collaterals by a perfusion scan. We have to have a one trunk with good inflow ending in a good outflow inside the IVC, with a very good outcome by complete healing of the ulcers within a couple of weeks. Looking on the extension of the process towards the common femoral vein, we have to have certain points that should be emphasized on. First, we should use a dedicated stent in the case of involvement of the common femoral vein. We should not extend our overlap into the below inguinal ligament, and we have to emphasize there is a high risk of stent occlusion when we extend below the inguinal ligament, and we should not encroach toward the deep femoral vein because this may entail jeopardizing the PTS symptoms, and we have to exert the highest effort toward crossing the common femoral vein by different kinds of CTOs and extension of our process more proximally toward the IVC. And when we stent the iliac system and the common femoral system, we may achieve a primary patency of 57% with assisted primary in 80% and a secondary patency of 86%. But again, in the presence of extension below the inguinal ligament, there is a 3.5, 3.8 fold increased risk of stent occlusion. And in such cases, disappearance of the collaterals is mandatory, and if the collaterals didn't vanish in front of you with a single trunk into the IVC, you have to extend your stent more caudally. In type 4 and 5, we got to go through an endoflebectomy and then proximal crossing towards the IVC. If we succeeded, we have to stent the iliac system, and in case of failure, we can jump toward a palm operation or bypass using either the saphenous vein in case of a good vein quality of 5 millimeter or more, or a synthetic graft if we have a poor quality saphenous vein, using either arteriovenous fistula in adjunct or not arteriovenous fistula, depending on the adequacy of the inflow and depending on the quality of the graft available, and again in the presence or not of thrombophilia. So in a case of type 5, in such a case we don't see any of the common femoral, the deep femoral, the common femoral vein, or the iliac system are totally absent. And in such a case, we got to go through an endoflebectomy, and we have to assess all the, to remove all the fibrotic material inside the vein until we reach a healthy area. And this is much more difficult than the thromboendoarterectomy of the arterial wall, because there is no aligned demarcation between the fibrotic material of the thrombotic material and the vein wall. So you have to be very meticulous because you may injure the vein wall at that time. Sharp and blind dissection are mandatory, and you got to conclude your procedure by assessment of the inflow from the deep femoral as well as the superficial femoral vein. In a straightforward cases with endoflebectomy, you can close the patch graft. This patch graft may be a saphenous vein or a synthetic vein if you don't have good quality of the saphenous vein, and then you go through more proximal towards the iliac system by dilatation and then stenting, and you have to extend the stent toward the site of the patch graft downward in your field of inclusion. You have to assess this a good inflow and a good outflow toward the IVC, like in such a case. If you do an endoflebectomy and it turned out by assessment of the inflow and the outflow, you have a good inflow on both sides, and then looking more proximally towards the, now you can see the inflow from the deep femoral, and again on the right hand side you can see the inflow from the saphenous system. Again, the saphenous system is very important because it acts as a good adjunct in such cases. Proximal extension will find a local stenosis, a stenting of the stenosis, and then a residual stenosis that can be further stented with a good inflow and outflow from this such site. If you have a poor inflow from the deep system of the deep femoral and the superficial femoral, and you don't have an access like on the right hand side, you can see this is a poor inflow that cannot support your stenting situation, then you have to consider bypass to the contralateral side. And this bypass can be used in consuming the saphenous vein from the contralateral side and bridge it in the suprapubic region, and we can use as a bridge graft. Part of the vein is connected as a patch graft to the original vein, and the rest of the vein is connected to a branch of the superficial femoral vein. And if you don't have a good quality saphenous vein, you can grow through a synthetic graft with an arteriovenous fistula, making a loop with a mark on it. Then you can close it with a very good improvement of the venous ulcer in a couple of weeks. And taking home message, the patency of the reconstruction of open surgical is affected by the quality of the conduit, the graft material, the venous pressure, and the thrombophilia, which is a common situation. The endovascular procedures are a viable alternative when we fail to do endoflebectomy in such cases, and the Palma procedure gives an excellent outcome with a good symptomatic relief. In cases of May-Turner syndrome with a mechanical occlusion, the outcome is great because it is a non-thrombotic. On the other hand, in the thrombotic cases, we have an incidence of 14% with occlusion and 10% of in-stent stenosis. And lastly, poor outcome can be expected in the presence of a long femorocaval venous obstruction. Thank you.